Welcome to the part 1 of 2 of this 2-part webinar series entitled The Digital Arch, Simplify, Streamline, and Scale. It is being presented by Dr. Timothy Serber, DDS, and Dr. Michael Drone, DDS. And we're going to begin shortly. And with that, it is my great pleasure to turn the reins over to Hallie Wyrick, Director of Sales, Implant Solutions, and Guided Surgery. Take it away, Hallie.
Thank you, Jessica. So I had the pleasure of meeting both doctors a couple years ago at a Full Arch Masterminds event in Tampa, Florida. Shortly after that meeting, the doctors made an introduction between Instarisa and National Dentex to explore the partnership and utilization of facial scanning in dentistry. So here we are today, as they're now going to present to us on the digital Full Arch. But a little background about both doctors first. Dr. Tim Serber earned his dental degree and specialty training in maxillofacial surgery at the Indiana University School of Medicine. He has extensive training in orthodontic surgery, head and neck constructive surgery, and now he focuses on advancing real-time digital workflows and being a pioneer for full arch implant conversions and protocols. He practices in Valparaiso along with Dr. Drone. They are great buddies for a long time, and Dr. Drone's background slightly similar, as he is also a graduate of the dental school at Indiana University, and then got his advanced degree in prosthodontics and maxillofacial from Indiana University as well. So he's been in practice in Valparaiso since 2007 with state-of-the-art equipment and specializing in full mouth reconstruction. So this is an exciting new topic for us and a new protocol. So we are really excited that you guys have joined us for this lecture series, and I will kick it off to Dr. Serber and Drone.
Thanks for taking the time out tonight. We're going to kind of walk through our presentation. Dr. Serber and I have been doing this digital arch approach for the last 3 years. And tonight our topic is simplify, streamline, and scale your digital arch workflow. So hope everyone is ready for a great presentation. And we're going to get going here in a second. I'll let Tim add some things too.
There's been so much happening in the surgical and dental digital workspace in the last decade, but really in the last 5 years, things have really just taken off. And as Hallie said, Mike and I are both trained here in Indiana. We happen to work right next door to each other, which is kind of how this relationship started. I've got a surgery practice here with 3 locations, and in my central location here in Northwest Indiana, Mike's about 20 yards away. So we started to do really a lot of full arch dentistry and surgery together. And, kudos to Mike. Mike has been very progressive in integrating technology into our workflows and how we do these cases day in and day out. And I'm sort of the batch of surgeons that likes things to be efficient, likes things to be easier and better for the patient, and ultimately better for myself as a surgeon and the practice. And so what we're going to show you today, really, there's 2 parts to this, webinar series. Part 1, today is really just mostly an overview. We're going to talk a little bit about some history. We're going to talk about how we do things, and just kind of show you with this new workflow that now, is an offering from InSequence, NDX, really how you can integrate some of these things into your own practices. We realize what you're going to see today is a little unique because Mike and I we kind of have a team approach, which we'll introduce some of our other team members here on these slides. But this is really an amazing thing that's offered now. And, we are proof of concept here that this can really work. So I'll let Mike chime in for just a minute, and then we'll start moving on.
So I want to just kind of give a little brief overview of kind of our journey. 2007, I was the first team to do a full arch case at Indiana School of Medicine. And as a prosthodontist, we did all of our laboratory work. Around 2010, we started doing a lot of advances with our full arch, and we were trying to figure out how do we get out of doing the old conversion with the dentures. And I took a course with Mike Picos and one of our surgeons with Tim, and we started doing this guided arch with InSequence. And as we kind of moved through this guided approach, we had to figure out a different way to make things faster. So in comes Dr. Serber. First week I met him, we threw him a double arch. And then he and I started talking about, you know, where are we now with arches and where do we want to go? And the only way we can scale and streamline our approach to digital arch dentistry is to develop or work with different techniques so it's not of when can we do the next arch, it's how many arches can we do efficiently throughout the day, and kind of compound a day of doing, you know, 4 to 6 arches routinely. So I think right now what we're doing tonight is we're going to show kind of a workflow that we've incorporated about 3 years ago. And it's kind of how we work through day to day having a patient. We're going to work through how we bring a patient in, how we gather the data, and how seamlessly this patient workflow can go. Because if we had a patient come in tomorrow and we had an opening, we can start the surgery right then and kind of turn this around really quick. So we're going to kind of go through this a brief outline of how we're going to cover tonight's event, and then we will get right into it.
Yeah, so tonight, as you can see, we've got 2 parts to this. So tonight, as we said, we've kind of gone over the introductions. Mike's going to start, we'll kind of introduce the team and a little bit of our spaces here, but we're going to do a little brief overview of some analog concepts. You have to understand the fundamentals of everything, which I'm sure many of the participants and viewers tonight already know, but we're just going to review that because it's going to highlight how different the approach is and how much time and energy it can save you and make you efficient. We have a team approach to this. By no means is that the way that you have to do things. It's just what works for us. You know, I like doing surgery and not prosthetics, and Mike's the opposite. So it works well for us. And then we're going to get into really a little bit about the technology integration and how we utilize the technology with some of the, you know, the basic fundamentals to really take this to the next level when it comes to doing these arches on a consistent basis. We're going to have a pretty thorough case presentation today. There'll be several more next week as we kind of show you really how you can scale this. We'll have some Q&A today. Next week will be a little more granular, really with the integration of the InstaReza full arch digital pickup system that we use and what we're going to showcase here today and next week. And that's really what why we're here and why this is working for us so well. And that's, you know, they've partnered with Sequence to offer this to their providers as well. And so that's why this is now really attainable and doable for other doctors, most of y'all. So we're going to talk armamentarium, some of the surgical protocols in more detail, the prosthetics, laboratory protocols, several more case presentations, and then kind of talk, you know, lastly about the efficiency and the profitability that this can generate for you, because that's sort of the take-home message. You know, you can buy every scanner, printer, system you want, but if there's really not a good ROI or a way to become more efficient with that, you know, qualitatively and quantitatively, it's not really worth it. But this surely has been. So next, we're going to start with a quick little video, just kind of overview of us and how we do things here. Okay, you can advance. All right. So anyways, we've met us already. That's myself. my partner Mike, and then a face you'll see a lot in these videos is Alexandra or Alex. Mike, you can give her background if you want.
Yeah, Alex is one of our laboratory technicians. I have a in-house laboratory team, so she's one of our lead technicians and smile designers.
Okay.
That's been working with us. One of the important things for us is just to try to go over, I've worked at a implant center similar to a Clear Choice for several years, part-time. And, when you bring a patient in, this is just kind of bringing the patient in to kind of see how the office is set up. They have to know they're in the right place. The feel has to be good. So we meet them sometimes in my office. This is my office. We have our CT scan up. We have maybe a digital design, smile design worked up that we can show through a PowerPoint presentation. And then, you can see kind of on the right bottom screen, that's kind of my hallway. So it's kind of lit up to be a warmth feeling and lots of lights in the room from natural lighting. So they kind of know they're in the right place. Lots of technology going on in both of my offices, from the screen on the ceiling there to when we lean the patient back, the screen on the ceiling, Bose wireless headphones, speakers going to the music they like. So it's really creating a really nice surreal ambiance for the patient. And this is a setting where Dr. Tim Serber and Alex and I meet on the lower left. This is the conference room in my office. Sometimes we bring our patients down to this room and we present our treatment smile design. We go through some presentations with the patients. We do a lot of our team meetings here. On the lower right side is a laboratory that I own here at the office, so we can design some of our technology here. But, when you look through this, you kind of need a really good team approach. You need an oral surgeon or a periodontist involved. For us, it's surgery all the time, and we'll go over why. And then we need a prosthodontist. For me, this is my specialty, where I take over from diagnosing the patient along with Tim to working with the smile design to going through the plan. And then you need a laboratory, and you need a laboratory that's really advanced. I know N-Sequence, I've worked with them, a really high-end laboratory with a lot of technology that's familiar with the InSeries workflow. So you need those three parameters, and you need some coaching along the way with some of this digital technology, because it's a little overwhelming for some, but we're going to kind of break through some basic things that you need to get started. Okay, next.
The third location, which these are all very close.
Back up one.
That was the quick little. So this is where we do the surgical procedures. And again, with becoming more efficient, obviously it's pretty bare bones, but nothing fancy other than the ventilator we have in the back, because as most oral surgeons and a lot of private practitioners are doing, you do these under either, oral sedation or a IV type sedation technique. But just for efficiency's sake, we built in general anesthesia capability just because, we're doing 4 or 5 or 6 arches a day now with this protocol. So this works well for us. And this is where we're performing surgery. You can kind of move on to the next slide if you want. So the next slide is sort of our disclosure slide, but really I call it kind of our partnership slide, and just wanted to name some people and groups, who we're very close with. We do not have financial relationships with these people, aside from NDX, who's bringing us to speak tonight. But, Mike and his private lab team had very close ties with GC America. We've spoken for them for the last couple of years at their lab day in Chicago. We are set to put on a live surgical course, kind of presenting this live at their headquarters outside Chicago for at least about 100 doctors. They have a pretty impressive setting there in a surgical arena. We are very tight with BioHorizons. We're Teeth Express providers, which is sort of how this all started with our full arch game, so to speak. And BioHorizons has been great supporters for us. We're sort of partnering with them in putting on some of these bigger events and live surgeries and seminars. And then, of course, Insta-Riza. Mike, you can probably speak to your history with them more than me.
I've known the group from Insta-Riza, Art and Fernando, through the Coy Center. I do a lot of training with the Coy Center. So we met them a long time ago, and then we decided, hey, about 3 years ago, let's put a VIP course on, and they came out to our office. We did 5 cases, the 5 arches that day. They're, you know, like with any of these companies we're speaking with, one thing that I do like about them is their technology advancements. They have a lot of research and science behind their protocols. And for me, that all of the people involved on the screen, it's a phone call and you can talk to just any single individual. The support has to be outstanding to go through any of these digital workflows. And I think all of you that are involved in a scanner system, no matter what you have, if something glitches, you need to be able to pick up the phone. So we believe this team here that's on the slide is very crucial to our success from a single implant to where we are today. So I just really appreciate the foundation that we have with and the relationship we have with these companies. Okay.
So this slide, you can go ahead and click through this, Jessica. This slide just kind of highlights the team approach that we bring to the table. You know, you have to have your specialty knowledge and you have to have your expertise. Now, not everybody has to be a specialist to do these things, but really you just have to understand fundamentals, the fundamentals of surgery, the fundamentals of specifically full arch or you know, implant surgery, as well as the prosthetic and the restorative side of things. And if you don't have those down, some of these more advanced digital workflows can be a little more trouble than they're worth. You kind of have to have a basic understanding. We're going to go over that a little bit tonight. And you have to have communication and collaboration, whether it's between your team, like Mike and I, and our lab team, or your suppliers, your reps, your providers. You have to have good collaboration with them. Otherwise, you know, things don't go as smoothly. And a key point is, you know, you have to, the digitization and the incorporating of these digital workflows and all the technology, it has to enhance but not replace the basic skill set. So that kind of harkens back to the fundamentals of it all. And then the, you know, efficiency and efficacy. If I'm going to implement something, of course, it has to be efficient. It has to make surgery or a procedure more efficient for us as practitioners and business owners, but it has to be efficacious for the patient. And I could say this wholeheartedly, that this digital workflow, these patients are having tremendously better treatment outcomes than the old analog conversions and pickup ways that we were doing before. And, you know, I'm a surgeon that likes to do things kind of free-handed. So it's sort of ironic that I'm here speaking, you know, on behalf of InSequence. But you know, the stackable guide systems are great, done them all. The InSequence system is excellent. This is just an alternative that now, fortunately, InSequence, of course, offers to those of us that prefer doing things free-handed. There are still cases where you need a stackable guided system, but this is a really great step up. And, you know, we have put this photo in the background of this slide because, you know, what you notice is all the machinery and all the technology going around, but yet there's the team there that's focused around it. And that team represents the doctor, the assistants, all the people involved, the reps, the support, the companies. And that's really how these cases have to go. It's not one person doing things. It's everybody as a team. And we just want to highlight that sort of as we go through this. Next.
Okay, Mike. I'm going to kind of go through maybe 1 or 2 slides going back about 20 years ago, and even less than 3 or more than 3 years ago. We were always lining up a patient. We'd have a CT scan. At that time, we'd take PVS or alginate impressions. We'd have the mounted models, take some clinical photos, take some measurements of the face where we wanted things to be. We'd have to send this to the laboratory. We'd have a conversation with the laboratory team. We'd have a denture fabricated in case it didn't work. We couldn't load it that day. We also had surgical guides made with the clear duplicate with the trough cut out, the flanges reduced, and that would take about 3 to 4 weeks. And on this slide here, this was kind of going through the same way. We would, you know, take all these photographs, and probably now the photography is kind of diminished a little bit because we've introduced the facial scanner. So we have kind of another alternative way to get all the photos and line these patients up. So this is just a slide of kind of just depicting an old way of us taking the photographs. We still use it kind of for before and afters, but certainly not for the the treatment planning for our patients. We can kind of advance them. So then on the traditional surgery day, we'd have the case. So now we're waiting for the laboratory team to come to the office to be available for us. It was always kind of a scheduling pinch. And then we would review the setup with the surgery team. We would charge the video. We do all the measurements, the markings, recordings, and then we'd start the surgery. And the surgery actually was sometimes 3 to 4 hours, but it was much longer because we'd have to try the guide in and out, line up the cylinders. And I'm going back to a way that this is how I met with Dr. Serber, and we just said, we can't do it anymore like this. Then with the guide, we'd try to turn the abutment, select the right abutment, grind on the denture, try it in and out. And, you know, the important thing that Tim and I worked on was we have a patient in the chair that's in surgery, and we can't be messing around with this all the time of taking this in and out, you know, and adjusting. Lots of stuff were happening. Then after we were finished, then we'd have to fill this with some acrylic material, and we'd have to pick up the cylinders. And this was always a stressful thing to align it, to get the jigs to line up, the bite to index, nothing to get hooked up, not a cylinder ever came loose. You'd have to just all this monkeying around for sake. And it would take 45 minutes to an hour sometimes picking this up. And it was at the end of the surgery morning or the day for a double arch, and the patients are just exhausted. And then really, we didn't really benefit the patient by making this a better process. So then you had to then come back and do some adjustments. And there's so many complications or problems that may arise while, you know, going through this whole day that should be seamless. And we're telling the patient, this is an amazing way to get your bite back, your smile back, to change your life, all these things. And now we're kind of having to struggle chair side. Then after we got the denture out, we'd have to, the lab would come in and they would finish, or I would finish, and we would polish, and we'd put this in, and we'd go home and everyone's exhausted. So we kind of been working with Sequence along the way to kind of get a better way to do this. And then we were introduced with Instariza, and this really changed our whole workflow for patient enhanced viewing for, I want to say the word, patient's expectations, our expectations, and the outcomes for the patient. And then efficiency, we can line up 4 to 6 arches in a day and have the same outcome, one right after another after another. And we've been doing this for 3 years, so it's really changed. As we're kind of one of the leaders in our area to do these types of procedures.
I'll just add 2 cents to that. That from my perspective, I still do arches for other practitioners and general dentists in the area, of course, primarily with Mike. And when we have the analog system, there's also a lot less flexibility in some of these cases. And with this approach with Instariza and in Sequence, there's flexibility in how we have to do it. If I have a patient who's unhealthy but wants anesthesia, I have to go to the hospital, I have to go to the surgery center. Instead of, kind of me putting on multi-units, selecting those, and then having the lab try and pick it up at another location after that patient leaves the hospital, or try to change something, just turns into a logistical mess. Whereas in this case, if something needs to be changed, it's very streamlined, it's very quick, it's very easy. And we'll talk about that a lot next week. But back to digitizing the patient, Mike.
Yeah, so now today in my office, the patient comes in, and all of this is dedicated to team members, so I can be efficiently working with another patient. I just have to review the scans and come in and do my exam, which is pretty much completed by the time I get all this downloaded. So, for our office, we're all 3Shape users in my practice. So a team member's doing the 3Shape intraoral scans. I have a team member doing the Instariza scan. So there's some scans that we take that we'll show you. And then we come back with the Instariza scan. It's also a bite scanner. So we use that to do our bite scanner. And we have some face with the retractors that we take to grab the image of the face that we'll show you. We also take an exaggerated smile, and this will be our transition line that we use to diagnose. And then we take a natural smile and a lip at rest. And this is all with the facial scanner. So now, instead of me getting the right photograph with the camera and really spending some time to focus on this is all dedicated to a facial scanner. And so then this little quick sheet over here on that right side, if you can go back one slide for a moment, please. That little cheat sheet is just kind of just a little sheet I have of what reference tooth, what's the repose, what's the smile, how much tooth are we showing at smile, repose, what are we showing it as smile, high smile, And then on the right side of that is just a reference tooth on the bottom and kind of what we're showing. And just a little chicken scratch on the bottom, because then that's just a quick look at the patient, because then I'm going to focus all of this digitally with our laboratory and Tim together. So it really makes now a team approach come together. We're already digitizing the patient, and we're now reviewing this patient from facial driven treatment planning all the way through the surgery.
And how long does this take you now, Mike?
Now, this takes me maybe 5 minutes for me to come in and do what I need to do, because everything's downloaded already. So this is kind of an old way, because, you know, Tim and I were talking about, you still need to know some of the classic ways to do some of the full arch and how to do a denture setup. And not every case is a full arch case where we're doing the traditional all on X. You know, we have an article that's by Matrani and Dean Morton. It's in the JPD, and it talks about the lip tooth ridge classification. So these are some things that you have to kind of know. You know, on the class 1, you know, you have great lip support, tooth support, and the ridge is not resorbed. This may be for a more of a traditional case. And then when you kind of work down to class 2, class 3, class 4, you can see as we advance, we need maybe a little more lip support in the class 4 patient. The ridge has been resorbed, the tooth has been resorbed, so we may need more of a flange to kind of get the support. So these are things that we're always kind of looking at. It's just something kind of in your back of your mind. You need to kind of be paying attention to all of these classifications, is so we can diagnose the patient and provide them with the correct treatment outcome. Okay.
Thanks.
So just kind of some things to look through here. These are some slides of kind of the old way of doing some things. And I want to kind of go back, because these are kind of more traditional foundations of prosthodontics. We would take an impression, we would lute some cylinders together, we would pour the model up, we would put some acrylic jig, we would section them. You could use bars. There's all different kinds of techniques how to do this. Stone impressions, take a master impression, pick this up. On the top right, this is where we were really heavily into stone jigs. So after we took the model, we would make this little moat, and GC makes an impression or a stone material that has the lowest expansion of any stone made. And we would lute this together, let it sit for 24 hours. This is a patient. I put the top jig in, the bottom jig, and you'd wait there to see if there's any fracture. If there was a fracture, you knew your impression was incorrect. And a lot of laboratory teams weren't even accepting a model unless this was performed. So I know all the workflows from the laboratory side. And then on the bottom screen, this is where we would be with the pecton frame. We would try the frame in, we would check the gingival tissue, we would have Emax crowns cemented onto the frame, check everything out. And then we would send this back to the lab so we can do some composite layering. This slide is many hours of work in the laboratory and many hours of work in the chair time for the doctor. And you start breaking down how much time you're doing this, and it's significant. I mean, this would take, you know, weeks to get back and forth from the lab while you're trying to get to the patient, from saying 4 months later they're healed and they're healthy, and now they want their second set of teeth in the next week. This is going to take maybe a couple of weeks to a couple of months to get back to this stage. So with this workflow, we're going to kind of move forward out of the analog way, and we're going to kind of now start showing you how we're doing it digitally. So we can advance.
Back to this touches a little bit on the slide that was 2 slides ago with the LTR classification, but for the fundamentals, from a surgical perspective, you know, even though this workflow allows you to be very efficient and rapid in data acquisition and even working up the case, you know, you're taking the facial scan, you're taking measurements, you're merging things in Exocad with your cone beam through, you know, in sequence, you still have to take a step back and go back to your fundamentals, which I do for every case, even if I'm doing, you know, 2 double arches in a day. And this is just kind of what I think about. You don't have to do a cephalometric tracing, for example, but these are the concepts that you have to keep in mind, both surgically and prosthetically. For those of us in oral surgery, you know, we had to draw these things out several times a week. But, you know, when you look at facial norms, and if you're doing a hybrid type of appliance or even an FP1, you have to keep in mind the landmarks, because essentially what you're doing in a lot of these cases is almost an orthognathic type of a procedure. You're restoring not just dental tissue, soft tissue and bone, and you may be moving it. As you all know, a lot of our patients are not the perfect class 1 skeletal facial relationship patient when they come to see us for these. So, I look very, very briefly, at least now, I can do this in, just a few minutes, but kind of evaluate the SNA and the SNB. And, the A point there in the anterior portion of the maxilla is that point that relates to the S and the N in the upper part of that picture, and it's an angle. The S and N really doesn't change. There's sort of facial norms there. And that angle, if it's greater than 85, and depending on the literature that you read, some will say 82, as well as for different demographic groups, but greater than 85 means you're protrusive in the maxilla. So you're probably going to be looking at a class 2 type of a patient, and you need to think about that as you're planning, even if you're planning it digitally. You need to think through that and see where you're setting the incisal ledge and what kind of lip support you're going to have. Concomitantly, less than 78 is maxillary retrusive. So that's a patient that's probably going to have a skeletal class 3 type of relationship. And in those patients, when they're beyond those ranges, you have to think about what that prosthetic is going to look like. Your lab is going to do a great job, and Sequence is going to do a great job at setting that up. But you have to understand there may be a flange on the maxillary or the mandibular prosthetic, or it may be contoured to correct for those things. So you take that all into consideration when you're planning these cases from a surgical perspective, how you're going to place your implants, are you going to angle them, procline them, retrocline them, and how you're going to adapt your multi-units to compensate for this so that they have a great occlusal relationship, lower facial support, and yet it's hygienic. The lab and Sequence are so great at doing a lot of this for you, but you have to kind of keep all this in mind, because as you start to do arches more efficiently, sometimes you just forget to look at these things, and we've all done it. So just some good kind of surgical points to remember. You can advance, Jessica. Go ahead, Mike.
So we're going to begin digitizing the patient, and we have a 3-step approach with our protocol. First one is the consultation, and we are going to get the records, and this is where we're digitizing the patient. And then we have surgery, and then we're going to talk about the provisional delivery.
And yeah, this is back to what Mike was talking about earlier, all those steps and all that time to gather the data, gather the records that would take weeks. You see a patient, they are so excited, they're ready to start this process, and you hit this 4 to 6 week minimum lull of, collecting the data, the photographs, the measurements, and then having the lab do an analog workup. Just took a lot of time, and you lose the enthusiasm. Whereas in this case, with digitizing the patient that we're going to show, it's really a very quick 3-step process. Just today, I saw a patient in my private practice that I knew could benefit from a full arch. And today, in about 2 hours, we got all the records done, went over to the laboratory side and Dr. Drone's office and essentially have that case ready to go. It's just finding a date for surgery now. So it just allows a really high level of efficiency, which is what we're going to show. And you can move on there, Jessica.
Okay, so I want to talk to you a little bit about the technology. This is where sometimes it can be a little bit overloaded, but this is also a time where you need to partner with a couple companies to help you make the right decisions. So if we can fast forward through this here, please. So I'm going to let Tim talk to you a little bit about the CT scan.
Of all the technology that we're going to show, probably, the oldest now is the CBCT, and that's the fundamental basis of all of this. You have to look at the bone support, of course, before you can move forward with any of these cases. In our offices, we happen to be CareStream based with our 3D imaging. Oral surgery's very heavily CareStream dependent in the market. So we have 9600s. I have 3 offices, and we got 3 of them, and they work great for what we need. And we integrate the CBCT data into exocad when we're planning these and merging them with the pre-op scan. So it all starts with the cone beam, and then we move on from there, which is no surprise to anybody, of course. Next.
So for us, intraoral scanner, we are a heavily 3-shape base. You know, the unique workflow between our office, my office is, like Tim said, 20 feet away or 20 yards away, and we ironically have the same CT scan, the same intraoral scanner. So we have in our pros practice 6 intraoral 3-shape scanners. 3 are the Trios 4 and 3 are the Trios 5. They're running all day long with all of our team members. This has been kind of our workflow for us since about 2008 with the intraoral scanner. So this workflow can work with iTero. It can work with Medit. But this workflow is very seamless with 3-shape. So we really like this 3-shape scanner, and it's probably the best for us to gather in our needs, especially during surgery. It's really good at capturing it. I also know this works with the Prime scan the workflow, but for us, this has been our go-to scanner. So if you can get one of those 4 scanners, I think you'd be in great shape to begin the process of gathering the data. Because from here forward, everything is digital. So no models are going to be made, nothing else besides a digital scanner. So this has to be the most advanced and most important decision-making for you as a clinician to get the records accordingly. Okay. So this was kind of our missing link. This was the Instariza facial scanner. And for us, there can be many debates as to what scanner you want. And so I don't really want to go down the venue of different facial scanners, why one scanner may be better by a company or why you may like the other scanner. I just kind of want to focus on this scanner. This scanner, we looked at several scanners on the market. And for this one, it became more of a best scanner for us because it not only has a 1-to-1 ratio, which was important for us. I know there's other scanners that are not, and they have a different workflow. We just wanted to make something that was very seamless for us. So we felt this was the best one. We also knew the technology behind this and where this technology was going with this scanning company and the founders of it. And we also can use this as a bite scanner. And more importantly, we can use this as a laptop scanner so we can scan dentures. And so if you're not wanting to buy a laptop scanner, this can also use for your laptop scanner as well. So this was kind of our missing puzzle on connecting and digitizing the face, because earlier we're using photographs and trying to align all the photographs. Now we don't need the photographs. I don't need a facial scanner that captures the eyes at all. We know that there's certain landmarks on the face that are consistent, and you just line those up and it works perfect for us. I don't need to know about the pupils. I don't need to know the size of their eyes or if one's off or not. We're not using the eyes for the planning of the face. So this works great for us. Patients close their eyes and it kind of goes around the face. We'll show a video of this, kind of like a mini strobe light, and we've had no complaints about the strobe light being too intense for their eyes. So this really works great for us. We have 2 of them in our offices, and they're running all day long for planning for full arch and or any cosmetic case for us.
I will also say from the patient's perspective, when these facial scans are captured, it is a wow factor for them. I think it really can help to separate you from the guy next door or, you know, a local competitor. Not that it's about that, but every time the patients see this, their eyes light up, they get more excited about it, and instantaneously they see their face pop up, and within about 5 minutes we can do a very quick pre-op kind of setup, wax up, and you know, they get a glimpse of what they're going to look like within a few minutes, and 15-20 minutes. And you know, if you didn't have that patient, you know, captured already, this really drives it home. And so it kind of really sells itself in a way. So you can go on.
And we'll get more into the Instariza scanner at our next week presentation. We're going to kind of go through the nuts and bolts in more detail and technical workflows with Instariza. We're just kind of showing an overview of how it works for us. So for us, you know, we have kind of 3 workflows we like to stay with. Zircon Zahn is our workflow for the full arches. We also use exocad for some of the design technology, and 3Shape we've used in the past for the full arch workflow. It's a little more clunky kind of coming in and out of it. So 3Shape is maybe more for our production. So we're kind of hopped in more of the exocad and Zircon Zahn technology for the CAD/CAM software. So you're going to need one of those softwares, and you can push, I think this plays a video. Yeah, so this is just a quick video of us where we had a patient coming in with a denture, wasn't happy with the locator denture. We kind of did a quick wash. We scanned this with the Insuriza scanner and 3Shape. We scanned the top teeth. She's interested in going to a double arch, and we scan and we just put everything into exocad. So this is kind of the initial workflow of scanner, 3Shape scanner, facial scanner, exocad. And now we're ready to design and ready to go to surgery because we already have everything together. So this is kind of a little mini video of kind of where we just the case of the technology reviewed so far.
You can advance.
So for us, we were heavy into the printing. We have 3 Envision Techs, 2 Asigas, a Straumann printer, and we kind of thought this was the way we wanted to go. So we were going to the printers. We were going direct to the MUAs. I don't go direct to fixture level. And we've tried several different print materials and several different printers. And this was kind of the way we used to do this. We would always have the printers. They were a little bit quicker for us. And it was kind of a quick way to make up a backup pair. If we wanted to have a template made really quick to show the patient to double check, or maybe they have some missing teeth or the aesthetic demands is a little bit challenging for the patient to accept on the digital and they want to see what it looks like in the face. So right now we're using this more as a backup or make a record base for something for a bite or maybe like a little aesthetic snap-on smile. So the printers, this is what we have in our office. We can advance, but we're using more of the mills. So this is the print material that we use. It's from GC. We use this print material. It works really good for us. And we use these for prepless veneers, for cosmetic cases, the snap-ons. And on the right side, this is just kind of our part of the area where we have all of our printers. And it works really good for us for that. But now moving into the full arch workflow, we're not really using the printers. We're heavily in the mill base now.
Next slide.
So we kind of were deciding what mills do we get. We spent a lot of time as a team looking at different mills. We spent a couple weekends with zircons on and spent a couple more weekends with zircons on. And so we started outsourcing some testing, and we felt that with the zircons on, we felt this was the best fit for us. It may not be the best fit for you. And Sequence has got some amazing mills that they use for their full arch cases. They're really well known for their full arch technology. But for us, you need a good mill that's going to get you the quality that you need for your full arch. So for our office and our workflow, we have the zircons on, and we have 2 mills. One's a wet, one's a dry, and we keep those separate all the time. So somewhere you're going to have to get into the mill technology, and that may be with the laboratory, or if you're kind of thinking you can do this yourself, it's not so easy. It's not just buy a mill and you can start milling and you can start doing everything. It takes a lot of work and a lot of knowledge to this and time. So for us, this is something you need to really investigate on what's your mill strategy and your mill technology you're going to incorporate. Okay,
Move on.
So just another view of one of the mills that we have here, just kind of everyday thing that we do in our office. So I just wanted to kind of highlight, kind of a puck being in there, how we're milling stuff. And then one of our team members, Mark runs the mills for us all the time.
Okay. All right. So after the background, let's kind of get into this now because I'm sure everybody really wants to see this working. So we're going to go step by step here through this workflow on one of our best patients. So this is Steve. There's a little introduction and kind of Steve's story. Every one of these patients comes with a story, and that's the best part about this. And so I love that we're able to bring this workflow to the table because it just makes their story even better. It enhances their end result. And so I hope through this, you'll see that, but we're going to start meeting Steve. We'll show you how he captured his data, how he started to perform his surgery, and how he went from there and got it all wrapped up.
Well, over the years, I would lose teeth one by one, and it got to where I had the lower dentures, and eventually I had like 10 real teeth left in my head. So I still had all my front teeth, but it was getting harder to eat, and I had to start doing other things that, I wanted to, be able to live a full life, eat whatever I want, instead of picking and choosing what I could eat. And you see the commercials about, you have new teeth the next day and things like that, or the same day, and it seemed like it was time for me to do that.
But Steve was tired of his smile, and he wanted a smile to match his awesome personality. That was my first impression of Steve. Steve was very comfortable with the entire process, and he really appreciated the work of me and Dr. Drone together. And I think he really appreciates what we do here at the Aspire Dental Implant Center.
He had lots of concerns because he has spaces between his teeth that he's had all his life, and he wanted to make sure whatever we provided for him, we could still put those spaces in, and he wanted to have teeth removed and the teeth placed the same day along with the implants.
Well, just going in for the operation to remove my teeth and put in the implants, I came in and everybody treated me well, and they put me in anesthesia, and before you know it, everything was done and no real pain, and just everything was ready to go. And then the next day I had my teeth. I mean, going through the whole system to walk in and thinking that I'm going to have these implants in that would have to heal or take a lot of time. It was very fast and comfortable.
And after the case, Steve has just been wonderful to see and watch him take on his new smile. And I think he's just a great outcome.
I feel like I'm back to where I used to be. That's a good feeling. Going from the beginning to the end, very fast, very thorough, very friendly, just a good experience all the way around.
So I think why do we show this video? Well, I think everyone knows this is emotional dentistry, and one of the important things is to have a company come in and capture this. And you're going to have to pay some money to have a really good video. This is just a segment, so you can share these with your patients, because they all have some categories. Someone has like a Steve story. There's another patient with trauma, another patient with maybe drug abuse or neglect. So you can kind of start categorizing your patient. And you heard Steve on the video say, well, it was great, he got his teeth the next day. And some days we deliver the teeth the same day. Sometimes we just have the patient go home and they ice pack, as we call it, and they come back the next day. And we can take a certain type of healing abutment off, and we can just insert these. It may take 10 to 15 minutes at most to insert these, with maybe a spot check on the occlusion. So some patients want it delivered the same day, and other patients we do the next day. If we're doing 4 to 6 arches, we're always delivering the next day to 2 days later. I've not had one patient complain about that. And that was probably something that Tim and I had discussed, is if we're doing this technology, are we getting the teeth faster the same day? And we can do that, or we can postpone it. And this workflow allows the patient to come in, minimal swelling, minimal pain, and it just works really seamlessly for us. Okay, can you click on this slide for us here? So again, the 3-step approach: getting the records, digitizing the patient, we have surgery, and then the provisional delivery. So we're going to kind of review the next steps. One of the important things for us is a consultation. So Jenny on the left is a team member of us. So you can tell this is her personality. She invites the patients in, she welcomes them. This is how we greet every patient. And then on the right side is where Tim and I together on our approach, we're able to screen the patients together. If Tim is seeing a patient first, he'll call me over and I'll see the patient together. So the patients really getting to see how we work as a team. So consultations maybe take, maybe 30 minutes for us. It can't be just a quick, 10 minutes here, 10 minutes here. We like to spread this out over about a half hour so we can build a relationship with the patient. And at this time, we are getting a lot of the records already for them. So they're kind of already engaged moving forward. So again, another way digital dentistry is helping us move along. While we're working with the patient, we've already taken some scans and records. And our next step is going to be ready to show them how we've digitized their smile versus telling them. So it's a really nice approach for us. Next. Again, we kind of went through this earlier. This is just a quick review of the scans that we're already getting as soon as the patient comes in. and some measurements that we're writing down so we can advance through this.
So again, as I said before, everything starts really with the cone beam. The patients get that before they sit down into the consultation room, as I'm sure it does with all of everybody watching today, because that's where we look at, what do we have to work with here? Not just dentally, but from a skeletal bone standpoint, grossly, generally, what are the options? Of course, most of these are full arch fixed patients. But if it's one where we really got minimal bone, we know right away how we're gonna approach this case, and then we can move forward with more of the record taking, the facial scanning, and digitizing that patient completely. So this is always where it starts, and there's no passing that up or skipping that step. So that's great to integrate. Next.
So CT scan, then we come in for an intraoral scan. I know this is just a picture of a case that we did, just to show patients that we're grabbing the scan right after this visit with the CT scan. We can go to the next one. And this was the technology is advanced, and we're just showing Steve's case. So this is where we're taking the bite scan. So we can have a patient come in. All we're concerned about is the bite scan here. And so we can take this with retractors. We have the high smile, where we're having the patient lift their lip, as we say at the Coy Center, show me your gums. So we're having them really squint and kind of do a Duchenne smile, and we're trying to figure out where the transition line is. So this is one of the scans we take with the Inserisa scan. We can advance. And then my team has also taken a natural smile. Again, we're matching facial scan to facial scan, so we're lining this up. And then the next image that we're taking is kind of a repose. Sometimes, as you see here, the patient isn't showing any teeth at repose. So there are some techniques that we have to record that. So if a patient's not showing in pose, so they kind of superimpose with each other. So we're kind of digitizing this patient. We've gone through a CT scan, an intraoral scan, and the facial scanner. So now we're ready to kick it into some software and start planning. So in our software here, we've lined up the case. We've scanned everything in. Sometimes it's very challenging to scan the lower arch or the upper arch with multiple missing teeth. There's a mush bite technique that we can use with the putty, and then we can scan the patient with the facial scanner. And we have some indentations on there. Sorry about that. And some markers, or we can just scan it take a scan like this in a bite and then kick it into our software and then start scanning. So we can advance through this.
I believe that's a video.
There may be a video here of this here. No.
And just to reiterate,
Oh, there's a video here. Sorry.
You can go ahead and play that.
Yeah. So this is just Alex showing us how we line this up, locked in the digital world. You can imagine sometimes if you had this in the analog world, you would be taking impressions, making some wax rims, taking some bites, trying everything in. So that's kind of not happening in my office for sure anymore. So this is all delegated by my team. And now we've stitched everything together, the faces, how the teeth look, the bite, and we're putting everything together. This is all through ExoCAD, and we're lining everything up in the software so we can do all of our facial alignments, because this is how we're lining up. Remember, I discussed we're not looking at the eyes. The pupils is not our landmark, and it's well known that that's not the way to line these up. And so then we can start kicking in the articulation system. And there's many articulators available to use. You can choose whichever one you want in the system. And so this is where we're trying to line stuff up together. Sometimes we're using different techniques to look at this. Sometimes we're using the Coist analyzer. Sometimes we're using a different plane for us to kind of start lining things up and setting the case up, so we can now see what the outcome should look like for the patient. And now we've kind of set up a case as if the patient went to surgery. This is what our expected outcome is. And then we can bring the patient into our office and we talk to them about this is what our design should look like, and kind of go through it. And this is really when the patients really engage. They're seeing, hey, this is a really nice design. They give some feedback, so they're actively participating in the outcome. So it's already kind of a very good success for us, because the patient knows that we've walked through the case and we're ready to proceed to surgery.
And this is pretty much what we review together as a team briefly before each case now. These, once they're worked up, we review the overall plan, everything overlaid. You can actually import the DICOM of the cone beam to sort of look at, where your bony structures are in relation to where, the teeth have been waxed up and designed. So that's when we sit down, and it really takes us about 5 minutes to go through everything, have some discussion on, what Mike's points are, what mine are, and making sure, we're aligned on what I need to do surgically, and then what we're going to do prosthetically as he finishes and delivers his provisional. So this is just such a great workflow, getting all this data right here together to review quickly, efficiently before every case. And it really, it's a tremendous workflow. So we can probably advance to the next one. So after we've done all that, it's surgery day. So again, 3 steps to this process. We've digitized the patient, and within about 30 minutes to an hour, captured the scans we need. There is a little bit of work for the lab to do, the pre-op design, but you can overlay it all, review it all, and then you're ready for surgery. We're done with the 4 to 6 weeks of waiting for the provisional denture to be made and the clear guides, or in our case, even the stackable guide, since we're doing most of these freehand. But that helps a lot in dealing with these patients. It takes a lot for these patients sometimes to just get through the door. And if this suddenly becomes a process that's taking them 3 months before they're ready to go, or even longer, so you lose some of them, and they can lose confidence. Whereas these patients, we can be ready within days, if not hours. So we progress to the surgery day. We always start by a little quick meeting. We review each case. We look at the entire overlay and the meshing of all the data, all the facial scans, all the cone beams, and boom, we're ready to go. This is just another couple cases and photographs of us. Mike is in there with me on all of these cases. And I think in a team collaborative type environment, that's really how it should be. I want to make sure that where I'm placing implant fixtures is going to work for him. I want to make sure that he's happy and the lab's happy with the multi-units. And so we are collaborative in all of these cases. And in our case with the general anesthesia we do on most of them, we're able to do this really efficiently. The pre-op workup is efficient. The surgery is workup. This workflow and the intraoperative incorporation of the digital tech, which you'll see here in a minute, we'll talk a lot about next week, allows the surgery to be efficient. My biggest complaint about the old analog approach was just the time factor. We forget about the patient in the chair or the patient on the table, and it's just not appropriate for a patient to be there for 8 hours or 10 hours. We're not thinking about their overall health, especially under anesthesia. And it's not about rushing, but you want to be efficient. And a single arch for us now is an hour or less. Some of them are 45 minutes, just depending on the dentition and the amount of bone reduction that has to happen. And the surgical time now, from the time that patient is induced to the time that they're either extubated and just doing the post-op pickup scans, it's about 2 hours, 2.5 hours. And so that's how this workflow builds in the efficiency and allows you to streamline your process and then scale your process if that's what you want to do. You can move.
I think one thing to point out in this, can you back up for 1 second? I want to touch on something. I think the one thing you can point out in these 3 pictures is, like Tim says, we're already meeting before. We've already know this patient. We know the design. So when we get kind of to the middle picture, this is where my team hops in. I've already chosen the abutments with Tim. We put the scans on. My team starts scanning here. And then you can see on the right side, Tim and I are going back to work. And our laboratory, your team can send this file to the laboratory for a quick check just to make sure everything's aligned. So we're checking this on the right side just to make sure everything's aligned. It's matching up with our pre-surgical plan and where we are now. And if we need to change an abutment, we can. It's very simple to do. So kind of right there, chairside, you can be on a team viewer with any person that you work with, the laboratory team. I know NSequence has this capability. They can check and make sure everything's moving along. So this kind of shows a lot of things going on and a lot of checks and balances throughout the case. Okay, next.
Another just picture surgery day. We'll see a lot of videos of these next week and some live stuff. But again, just showing efficiency. In this case, this is a case that we're pretty much wrapping up. We've got some healing caps on there. And, that's really how we finish the case after Mike's done the intraoral scans, which we'll show you. A lot of the armamentarium has changed and is still changing with the Instariza protocol. So we'll kind of go over, what the history of it is and where it is now and where it's potentially moving to. We're using different healing caps now, but it's all in the spirit of being efficient with what you're doing. Next. You can move on to the next. So now we'll get a little bit here into showing you the actual process of the digital pickup in surgery. So the intraoperative process for, how you capture implant position and how you integrate that and use that with essentially to do a digital pickup for the lab to fabricate your provisional.
Next. So I want to kind of walk you through, the screen's kind of busy. So the top left, on the top, in the very top left corner, we have a marker, and this is a bone screw. And this bone screw we can place in the palate, and we can also place it in the lower, in the mandible, kind of around the 24-25 area. And then we have a little scan body that snaps into here. Then we have this technique from this material from Instariza called Scandar. It's a recording medium, really rigid, and it's really picked up by the scanners. And we can place this bone screw in the scan body, and we squirt some of this up to another area in the mouth that we've designed as our marker. And then we start scanning our teeth. So this is right happening during surgery. And you can see on the top row how this all puts together. There's a bone screw with the scan body, and in the middle screen it's put together. And on the other right side is kind of some of the components that we'll work through. And on the two pictures in the bottom, just kind of show where the bone screw is in the left bottom screen and how we have all the scanning impression copings. And then we use the Scandar on the right. And that's our way we're going to be tracking our impressions for the procedure.
The detail, the armamentarium on the top there, these are some of the earlier iterations. There are several now and some for different applications, which we'll go into in depth next week. But just generally speaking, this is that, snapshot of the digital pickup. There are the bone screw that we referred to, or the artificial scanning screw, is really a fiduciary marker that the computer needs as a point of reference. And there's really several places where you can put that. We'll talk a lot about what those best locations are, depending on the case. We've kind of troubleshooted a lot of it for them. Mike and I have been doing Instariza now for this protocol for about 3 years. And, probably logged more arches than just about anybody, including Instariza themselves. So we've played with it, and there's several spots that are very consistent and give very consistent results, because that's sort of it does come down to the details. It's simple, but you have to make sure your reference screw is stable, that it doesn't move. Even the smallest amount of mobility can kind of throw things off and get you in a little bit of trouble, which of course we've done, and we'll show you some of our screw ups because we all have them. But yeah, this is generally how it's happening. So after, we used to be doing these pickup scans right after implant placement. Now with the new options in the scan bodies, you can actually do all the scanning after tissue closure, which I'm a big fan of. It allows me to just cut, close, move on, cut, close, and be done top to bottom, and then do scans after. So we will definitely get into the details of all this as well. Next.
So
this is a video.
So this is a video of one of my team members scanning. So we'll just kind of show you how this works really quick. So this is all, I'm placing all the abutments on the patients, and then my team takes over scanning. So on this slide, we're going to break down a few things here, and I'm going to let Tim talk to you about where he likes to place this, where we feel has been a great option for us on the location of this is pretty critical.
So when you get that patient ready to start surgery, whether they're going under anesthesia or not, before you cut, you have to, the first part of this protocol is to establish your reference points. We've got skeletal and facial references from our scan and dental references from our pre-op records. Now we have to capture that immediately prior to surgery with a stable reference point. And that's where I call a fiduciary bone screw is placed. And again, the design of these has changed. This is pretty much the most up-to-date design from Instariza. So for the maxillary arch, the first thing, the best place to place these consistently is in the mid palate. There's very dense bone in the mid palatal raphe. You do have to look a little closely at your CBCT. Some patients have a midline raphe that's actually quite thin. And so I've had a few cases where, I'm trying to engage that screw. It is self-tapping, self-drilling. A simple straight hand driver from either the BioHorizons or Nobel implant kit can easily place that with some manual pressure. But if you notice you're not getting great stability, just moving a few millimeters off laterally can engage some harder bone if the mid-palatal area is a bit thin or weak. Sometimes that raphe is a little more like connective tissue. So the maxillary bone screw for us now is always placed in the mid palate. You don't have to go super far posterior, but you do want to think about your surgery and your flaps and make sure it's out of your way. If you are doing a case where you have to do a lot of bone reduction, you need a big palatal flap. You don't want to be reflecting that flap so far into the palatal vault that you're going to move, let alone dislodge that bone screw. We really have to sort of leave it alone and try not to manipulate it during the case. So it doesn't have to be by the posterior hard palate, just sort of in the middle there is typically a safe location. And then on the lower arch, when we first started this, we were trying to place these bone screws actually in the retromolar area. But interestingly, that we found to be quite unstable. The original workflow for this digital pickup and with Instariza was to keep teeth. So you would place an artificial fiduciary marker, and you would actually select teeth to leave, 1 or 2 teeth that you would remove after scanning the patient, after implants were placed. Me being the oral surgeon and wanting to be efficient, I couldn't stand that because I said, this is slowing us down. And so fortunately now with these positions, we don't have to keep any teeth. We'll go into what some of your options are. You'll see some photos here in the next couple slides of cases where we've kept teeth to give you a couple ideas of what else is acceptable and will work. But this allows you the most flexibility. If it's in the office or if I have to take the patient to the operating room in the hospital for their health, we can place these fiduciary screws the day before, the night before, leave them in place, go perform the surgery and do the scans afterwards. But the midline, sort of in the mental region of the mandible, is the most stable position we've found in the lower arch. You can engage that really cortical bone there. The screw does come out at about a 45-degree angle. You can try to position it vertically, as we'll show you, but that's a real stable point, and that's really where we're starting in each of these cases.
And I think for me, if you can go back, I'm in agreement with Tim. I don't do any surgery at all, and I don't even take a tooth out. So I like to go in there, place these in, and say, Tim, I'll help you with choosing the abutments and checking some things out, but I want him to wrap everything up and him to be finished with the surgery. And then I just go do my part and the patient's done. So we have this for he and I, our workflow is just very seamless. And a couple things to point out on this bone screw. Down in the middle, you can see that bone screw is flat. And there used to be a little indentation on there. So now they've made that flat so nothing gets locked in there. And then you can see it kind of on the lower right how that scan body fits on that. now they have it so you don't even have to have that scan body. You can just track from the top of the titanium screw and slide over. So you don't need this. We just like this workflow, so it works really well for us. So we just like that. And on the bottom left middle picture, that is our healing abutment. In the earlier screens, you saw the BioHorizon white healing abutment. Now it's this titanium screw or titanium abutment that actually screws onto the MUA. And then we have these shorter healing abutments that snap onto that. So when Tim's finished, the healing abutments are on, the scan body goes on those healing abutment. I do my pickup. I take the healing or scan body off, and we just go right into picking up our soft tissue. And the patient goes home with these silver healing abutments, and they're nicely flared. So when I have to take them off, I have no tissue in the way, and these things just drop right in. So this is a really big advantage for those of you who do not have a scalpel in your office or want to have bleeding coming back or try to find this. So it's been the advances with this Insuriza group just keep getting better with all of our input. So kudos to Insuriza.
And as I mentioned before, there's some variations in the scan bodies. You see the very middle picture of those scan bodies that are a little taller. Those are the ones that go directly to the MUA fixture. So the initial protocol was to scan with the tissue open, and the scan bodies were direct to the multi-unit, which we can still do and still do on occasionally, but primarily now our workflow is to put the silver healing caps on and the shorter scan body directly onto those healing caps and scan. Okay, next.
So I'm going to walk you through starting in the top left corner, and we're going to kind of walk through a couple things that Tim and I have gone through in our journey. The top left is maybe kind of now where everyone can see. That's the bone screw, the scan body, and our first track of Scandar. Now we've changed the track to go laterally to the premolar, so because we don't want to disturb the tissue, because we can use the tissue as another marker for us. So we now just go laterally. So when I go over now to the right, two images, this image I can show you in the middle top is where Tim was talking. We had this in the retromolar pad, and then we would transfer down the Scandar to the premolar, and we would scan this. This technique, we had a lot of the screw kind of loosening up. It's always in the way of the surgery. And so we talked to the Insuriza guys with Art and Fernando and said, look, we need another alternative way besides that. So we started then venturing into keeping a tooth. And then I told Tim, I don't want to have to go back and take a tooth out when I'm done. Let's be finished with the patient. So the very far right one shows where we kept a tooth as a marker, and we no longer do that technique anymore. Then we had another technique. It's kind of on the bottom screen. You can see the two front centrals are there. This is actually where we place two implants. We put two MUAs on in the scan bodies, and we luted this with Scandar, and this was our marker. And then we would take those off together, keeping the Scandar intact, do the rest of the surgery. And now you can see on the far right, we put those two back on. We added two more scan markers, and we added more Scandar and attached it, and that became our scan. So that was a record for us. And you can see on the far bottom left, that was how we would do it in the palette on the case above. So this is kind of an overview of how we were doing this. And I think the next screen shows kind of our favorite way now. And you can just see that was kind of moving just around. Maybe not. So our favorite technique is the scan bone screw right here in the lower arch and the palate, and we just go for it. It's been our most accurate alignment. So this just kind of shows how after the day of surgery, Alex has a video of the day of surgery, how we're lining up all of the scans that we've taken. We still take a putty impression during the surgery for the soft tissue, so we can use this as an alignment strategy. And the nice thing here is you can see on the posterior left, we ended up having one a little more angulated than we liked, and we always can switch that out when we go to the next step. We just pop off the MUA, put a new one on, rescan it, and we can take that one back off, and we kind of note, hey, we have a new change on MUA, and we can add that when we go seat the final. So it really works really well for us. In the analog way, you'd have to stop, take a new impression, ream the cylinders out, pick it back up. We don't do that. We just switch them out, put the hybrid back on and keep going. So you can see we're a little offset there on that one. So
Every prosthodontist will complain about AP spread. So my goal is to give Mike the biggest AP spread that I can. And then I do like to mess with them a little bit. And, when I put on a multi-unit that's a little bit distal angulated, I know it's a little bit of a reach for the prosthodontists that don't like sticking their fingers that far back there. So it's really just me messing with my colleague here. But again, this just represents really what's happening immediately following those scans. In our case with the lab in-house, we're starting the overlaying and the merging of pre-op design with the Instarisa scans that we've done intraoperatively in the mouth to overlay the pre-op design and essentially start fabricating. So from here, this is going to the mills. As Mike said, the provisionals are being milled. And this workflow, it's just seamless. And again, if at this point we discover, we're not happy with the position of a multi-unit, well, now there's no cylinder to remove. There's nothing to be ground out of a provisional denture and start over. It's simply changing the angle on a multi-unit, doing another scan that might take us 10 to 15 minutes, if that, and moving on. So this really has made troubleshooting and just doing these cases so much smoother.
And I think adding to this, it's really important, because as a surgeon, I sometimes want to tell Tim, move it this way, move it that way. I'm not the surgeon, and so I'm trying to connect with what I believe I'm seeing. And then after we do this case, the first thing Tim does that I really respect is he comes in that room and say, how did I do? How did everything line up? So this is kind of some instant feedback for him right away on every single case, how we can change this, how we can make this better. So from a patient outcome standpoint, moving forward, this is kind of an educational thing for both of us. And we review this right there. So really nice way to do this. Okay, forward, please.
I think we saw this.
So this is kind of a video video that we just saw.
Yep.
Some similarities, so we can advance through this. So this is our milling group. So we go ahead and we mill. We use the GC OptiGlaze. This has been kind of a workhorse for us. There's different techniques on how you apply this. Some people are getting the fingerprint lines through this. So there's some ways to manage that. But this is how we are using this. 15 to maybe 15 minutes or half hour is maybe all we need to go through this. So we have our whole team of assistants. They can do this. It's really nice. And so you can see we're just spending a little time, just as I call it, watercoloring the gum tissue and maybe do a little texturing for the teeth. Okay,
next.
And so this is a picture of Steve in a prototype. We had to change it because we had this closed. The diastema was closed, and he came back and said, guys, this is not me. I've always had a gap in between my two front teeth. So the nice thing is, after we had closed it and he said he wanted a gap, we kind of decided how much does he want to open up. We just kind of took it off, made a little diastema, and then we put it back in and rescan it. And we just milled him out another one just to kind of show him, just to kind of tidy it up a little bit, make it nicer for him. Okay. So again, you can see now we get ready to go to the final, I believe, here on this. So this is just a video of everything that we're working through. Alex just showing you kind of how we're lining everything up. So now we have everything lined up and we're placing this in the face. And this is kind of where we're making a decision on, abutment selection. Is it going to be an angled abutment? We're going to use a different type of screw. Maybe should we change an abutment somewhere else at a different angle? So these are some things that we've kind of already worked through, and we can go ahead and go forward to the next screen. And this is now where Alex is doing her technique. I'm not going to get onto the details of this, but for us, we do a lot of intrinsic staining. We feel this has some infiltration, and we really like the zircons-on material. And so we stick with this. And it kind of, as we go through this, it really kind of intensifies as we go through. So we have a little bit more of a lifelike approach, a lifelike appearance to the teeth. So we can go ahead and go to the next screen. And you can see this is where you can see the root eminence. Some of the coloring is starting to show through in the zirconia, so it doesn't have this, kind of a blah appearance, and it's a little bit tough to kind of get the gum tissue coloring with just being monolithic. But all of our teeth, everything's monolithic. We have done some where we've left the incisal edge and we've layered a little bit, but for the most part, everything's monolithic. We do a little facial gum layering, but that's becoming better and better each time with some events that we've attended and some pearls. So we can go ahead and advance through this. And you can see Alex continuing. This is where she sometimes gets a little fancy with putting some gingival layering on. So just kind of some patients a little bit more demanding on how their gingival tissue looks, and we can kind of get an idea of this through our prototypes. So Alex then will decide whether she wants to do some gingival layering or not. Okay. And now we're using some GC products for the gingival layering. This is just showing how she can kind of go from in the lower left, where she's now getting close to being finished on the upper right. Okay. And so this is kind of where we're looking at getting close to the final. So you can see this is shaping up really nice, and you can screen forward. And again, some paste that she likes to use at the end for some final touch-ups, our GC luster paste. And now you can see this is our final product. So this is kind of what we're expecting the patient to place this in and have a really big wow factor for the patient. Okay. And this is what the lower looks like now. And upper again, kind of dialing in on the anterior. And I know there are people that do not like the tie bases. I understand why we have some cases where you have some mixed tie base, mixed straight to the MUA. For us, honestly, we've had no fractures doing this technique at all. We have had one tie base come loose. And that was a technique early on that was a fault of ours. But so far in 3 years with our group, we've not had anything more than that. So and I know all the prosthetic traditional principles, so I haven't forgotten those. So we're very particular on how things are treated preclinical, in the clinical, and in the laboratory. But we like to use the GC cementations for this. Okay, we can advance. And this is a final. I know he has a little bubble there. Sorry about that, but this is kind of in the mouth, just trying to focus on the anterior. Okay. And another close-up picture there, just trying to show some of the detail. All right. And this is Steve. And, you can see on the right side, he's a really funny guy. I mean, he owns a butcher farm, so his nickname was Butcher. That was his nickname. So this is a really good character. I mean, he would, right now, if he was here, he'd probably tell you his whole story for us. So, but this is, this guy's been out 2 years, and he comes in, jovial guy, loves what he has. No issues so far. We do give him a night guard at night that we have from Great Lakes, and he couldn't be happier. So these are kind of the outcomes we get with the patients, and it's a very quick outcome for us that we really have. And Cerise has been very critical. It has really changed our practice outcomes financially, and of course aesthetically. And patients we are now the true implant center for full arches. And we have implant centers all around us. We're not too far from Chicago. We have lots of those that we compete with, but really for us, this is becoming as soon as we started this 3 years ago, it really took off. And I'm going to tell you, the support from Insuriza is top notch. BioHorizons with us has really helped some of our marketing programs. We couldn't be happier with BioHorizons. We've used them exclusively for arches. And N-Sequence, we use N-Sequence. I want to kind of talk a little bit about this because we didn't mention this too much, but Tim and I like to do things free-handed. One of the other partners likes to do it fully guided. One of the other partners may like to do it maybe just with the guide only for the pilot holes to align things up. This Insuriza workflow and this technique they have works with all of them. You can be free-handed, you can be partially guided, you can be fully guided. There's many ways that we'll talk during the next presentation. So you can choose whatever you want. But in doing so, you need a laboratory that understands a fully guided workflow, that understands how to put the parts and pieces together, that understands what you're going to use to scan as a marker. How's this going to work? And NSequence has this down. I mean, if you've been to any of Mike Pico's courses or Curie Levitt's, you've seen this technology there, and it's only getting better and better.
Yeah. I think as many of you are probably sitting there wondering is, you know, gosh, how do we do this? And obviously Instariza is a big part of that, but you know, your support now is NSequence. You know, they've partnered with Instariza to bring this really to everybody. And so, you know, we're just, like I said, proof of concept that this works, and it works really well. And to just take a step back, you know, from a very qualitative overview, you will notice very quickly the outcomes in these cases. I really can't overemphasize how great they are. Even patients in their provisionals, when you have a milled or even a printed provisional, the aesthetic result is leaps and bounds above what has been done, you know, from an analog traditional pickup method, and the patient satisfaction is off the charts. So these people are so happy, and that's a week after surgery, and they still have this final design and final delivery. And you know, the excitement just goes up from there. So this package, this workflow has done nothing but good things for us, you know, professionally and for our patients. And, you know, we're excited for every arch that we do still. It does not get boring. And this has made it really, really enjoyable. And it's just made it even better for the patients. They have a better workup to surgery, a much better, more efficient surgery, and an even better end result. And people are just thrilled. So I can't speak enough about it. And, you know, we're happy to share this all with you. If you want to go on to the next slide. So next week, we're going to get a little more granular about this. I'm sure there's a lot of questions about it. And of course, a lot of the details NSequence can supply with you too, especially if you have questions about what your options are for restorative materials and how this works on their end. But we're going to get really detailed about the Instariza concept. I know you kind of saw it in practice in a case here, but we're going to dive into the armamentarium, get a little more detailed with the surgical protocol, really what the steps are. I can walk you through an arch, several arches, to just show you here's how I'm doing it, and you know, take what you may from that. And then some of the prosthetic and the laboratory protocols that we do. We just want to kind of break it down a little more itemized for everybody, so you can kind of see that. Today was just kind of showing you how it works all together. And then again, show a few more case workflow presentations. You know, Steve was a case we've done a couple years ago. We've done several hundred since then. But we've got several others to just show you, to kind of drive home the point of how this all works. And, you know, you have to have consistency in what you do. And this is a very consistent workflow, and therefore it works. So we've got consistency, and talk a little bit about the efficiency and the profitability of it. Just, you know, from a practice owner, Mike and I both, you know, like I said earlier, if this isn't allowing you to be more efficient and ultimately more profitable, it wouldn't be worth it, but it certainly has for us. And of course, we'll have time for question and answers. Please feel free to email myself and Mike personally. We're happy to, we love talking, sharing tips, pointers, questions, concerns, whatever you have. You know, we're kind of open books, so please feel free to reach out to us.
But a couple take-home points, you know, to do the full arch, you know, we try to schedule everything, be efficient, see patients at the same time in your office. You know, for the restorative team, you may have to leave to go to the surgeon's office and close your practice down for a little bit. We understand that. So what's that going to look like? Well, let's say you have a couple in a month. You may say, well, how many can we do in a month? How are we going to manage my practice restoratively? And this, now what we're doing is, how many can we do in a day? How efficient can we be in a day to close down our practice with our staff? And how many can we do in the day? I can tell you, Tim and I can do 5 to 6 in a day. We can start at 6 and we're out at 5. And we stack them that way. We've done 3 or 4 days in a row. We've done that. And there's many ways you can do this. And with NSequence's technology, we have patients that we have to go to the hospital, and I'm not allowed in the hospital. So Tim understands this workflow, and Sequence understands the workflow, and they go to the surgery and they're doing everything. And I'm just waiting for everything to someone to tell me, hey, we're good to go, and they can send it back to me. So it's really next week we're going to get into all of the technology and techniques to go through this. But we just want to give you a little overview of like, hey, this is our day-to-day practice. I really appreciate Sequence supporting us and everyone that joined us tonight. I hope you got kind of what it's like day-to-day of practice for us doing this. And next week, we're going to really hit into it. All right. Thank you.
Great.
Thank you,
everybody.
gentlemen. We do appreciate your time with us here. Thank you, audience, for joining us. Thank you, Hallie, for being here and being great support. Tremaine, Nicole, thank you for being our backup dancers in the behind the scenes. And take care, audience. And please don't forget to tell us how we can take care of you.